Welcome to the Experience Shift, where we share insights for healthcare transformation.
I'm Brian Wynn, Senior Vice President of Growth at NRC Health.
And I'm Jennifer Barron, Chief Experience Officer.
Together, Jennifer and I will explore how the experiences of patients, caregivers, and consumers are changing the rules of healthcare.
We'll talk with leading executives, innovators, and thinkers who are challenging assumptions, turning data into action, and reimagining what healthcare can be.
So whether you are in the C-suite, leading a clinical team, or driving innovation, you'll find real stories here and strategies to help you lead change.
Let's shift experience, starting now. Welcome to the Experience Shift. We are glad to be joined today by Dr. Tom Howell, a practicing obstetrics and gynecology physician, and a physician leader with deep expertise in patient experience. Dr. Howell has served as the medical director of Mayo Clinic Health System and most recently joined NRC Health as a physician advisor. We're so glad to have you on today.
I'm thrilled to be here. Should be fun.
So I would like to ask you a little bit about your career. You have spent a long time, several decades, championing patient experience and championing clinicians developing an experience mindset. Would love to hear from you what got you interested in that work and what is your why? Why do you stay involved?
Well, you're right. It has been a long time. Just last week, I had a patient's husband ask, well, how long have you been doing this? And I kind of flippantly said, longer than you've been alive. And they said, no, really. And I said, how old are you? 31. Yes, longer than you've been alive. So really is true. I started out in medical school, really hardcore pediatrician. That was what I was going to do, set my whole schedule up around that. Found that I loved surgery and was looking for something where I could have a relationship with patients, but still be able to operate and do surgery. And so OBGYN kind of fit that. So I went into that, found that I had a little bit of aptitude at it. And then as time goes on, you discover that really what drives my satisfaction was the connection you make with people and the relationship you develop, and that they send their friends because, oh, you have to go see my doctor. And then now I'm having patients, delivering patients I delivered because their mom said you have to go to this person. And so that's really drives the belief around what matters is relationship, and what feeds you is relationship. You know, I don't go to bed and say, that was a great surgery and they had this complication and I handled that so well. It's cool that we can do that. And I'm glad that we have skilled professionals that can do that kind of work. But really the thing that drives you is when people come back 2 weeks after their surgery and you say how they're doing. They said, oh my gosh, it's so much better. And that's the neat part about this.
Yeah, that's great. You have been a very vocal champion of the patient experience from the physician's perspective, and that is a bit unique. I've been the guy in the room in front of hundreds of physicians and trying to talk about patient satisfaction metrics or something related to the patient experience. And you have to learn how to kind of bob and weave when you're delivering that kind of message, not being a physician myself, but you do that work. And you're out in front of your peers talking about the importance of patient experience versus patient satisfaction. What do you find to be really helpful by way of metrics? You know, what metrics do resonate, or how is it that you're articulating the value of the patient experience to fellow clinicians?
Well, and I think this is going to sound a little odd coming from, national research company, but data is not the answer. The data is a tool. So when you show up, especially with physicians, and say, here's your report, here's the things that you don't do well, or patients tell us that you don't do well, do better, that doesn't resonate because 80% of the time that's going to be a positive response. And so those confidence intervals and those statistics on an individual basis don't work very well. And doctors are smart enough to know that. But what you can do is ask, what do you care about? What are your values around patient care? And it's going to be different for different people. Okay, what does the data tell us how that's going in the patient's perception? What things can we leverage as tools to help you do better? And then how do we measure how your progress has been on things that you care about? Because at the end of the day, it's more about what the patient and the physician build together and that relationship that drives the satisfaction on both sides. And it's not about whether you did AIDED or not. And, no nurse, and speaking of, from a broader clinician standpoint, no nurse goes, I'm going to really work hard with Mr. Johnson to help him have a great day recovering from his surgery so that the hospital can get $100,000 of HCAPS money. Nobody cares about that. But so Mr. Johnson's, when his wife comes in, she's going to say, hey, that's great. He's making such good progress. That's what drives us and feeds us. And I hope that's why everybody's in healthcare in the first place.
Yeah, we've had many discussions about that. Matter of fact, at NRC Health, we frequently talk about the benchmark that matters is 1, N equals 1, and relative to our mission of human understanding. I think that's what you're referring to, Tom, is if we can get at what is most important to an individual, then we have an opportunity to serve that up at the right time so that something can be done about it. Is there something that you have seen be revelatory in that way? Have you seen that type of insight being delivered to yourself or your clinician peers?
Yeah, I think that where people get sideways with this is and organizations, even on a bigger scope, they think of this as a problem to be solved, right? It's not really a problem to be solved. It's a whole bunch of competing things that are going on at the same time to be managed optimally together. So when you think of it that way, it's all lots of little things that we improve, that we try and do better. And then we get back to, what's the ROI on this? And then the people in the C-suite now, and I've seen this over the last couple of years, really come back to the question that we had about 10 years ago to say, why do we care about this? And my initial thought was, you care about this because this is why you're in healthcare. That's what makes your job cool. And why you won't say, I get to go to work on Monday, not I have to go to work on Monday. But I think there's tons of data that says the ROI exists and it's very powerful. And there's a big study that has like 429 positive responses as far as improved efficacy clinically and patient safety. 127 studies that were like, that's kind of neutral, and 1 negative study. So that data is clear. It's just not easily measured on an accounting sheet. Straightforward. So it's getting people to understand that. And I think a place that the C-suite can get some insight is by listening to physicians, and the physicians and nurses and other clinicians need to be able to talk about, I really had a great day today because this went well in my relationship with these patients. And the first rule is take care of the patient, and the second rule is take care of the patient. It's not follow the guideline. It's not do this so I don't get sued. It's none of that stuff. It's just, you went to school for a long time to know how to take care of this patient and problem solve in this moment for this person. And when you do that, it's incredibly satisfying.
So, as you know, I've worked in 2 different health systems in the experience space, and I have talked to hundreds of physicians over the course of several decades. And oftentimes I hear from physicians a frustration that they feel they don't have the proper channel within a health system to share ideas with the executive team. And they're, physicians, as you know, you're on the front line. Like, you see the experience, you're living it every day. So,
and we kind of inherently feel like we're the executive team.
There we go.
There's some of that too, right?
So have you seen anything in that space that you feel has been done well to create a pathway for physicians to elevate ideas or to open conversations, larger conversations with the executive team to improve operations and experience?
Yeah, I think the single biggest thing that I saw that was effective was we moved away, when I was at Mayo Clinic, from artificial target setting to an idea of continuous improvement. So the goal is not to be at the 90th percentile for everybody to be there, which one is statistically impossible, right? Because as people move up, that number keeps moving. They're just moving the goalpost forever. You can never get there. Yeah. But to be better today than we were yesterday. And if you're doing great, just to maintain that. And I think that idea resonated much more solidly and quickly and with a lot less angst than well, you want me to be at this number, but my partner's been out for 6 months, or you cut my nursing support, or people don't answer the phone for 30 minutes, or I have no access for 3 months. All of those, you start the litany of excuses of things, right? So we're trying to get incrementally better from wherever it is that we're starting. And how do we all do that together? And I think the second thing from a C-suite standpoint is, don't ask the question. If you don't want to answer, you're not going to do anything with it. And that's the biggest path towards disengagement, right? I don't trust what you say because I see what you do. You say you care about all this, but at the same time, you're doing these things that are detrimental to this proposed value that you have.
I'm sure that plays a role in shaping the experience mindset of a physician as well, right? That whole connection between how well they're feeling listened to and how involved they're able to be, how much autonomy they have in their practice.
Well, and it gets back to, the basic, that whole extrinsic versus intrinsic motivation kind of discussion around what really drives people professionally, especially in jobs that require complex thinking and problem solving, is the ability to be competent, the ability to have some autonomy. So I feel like I have some control over not the big thing, but like my day-to-day stuff, right? And then what I do has meaning. And one of the things, a little bit of a squirrel here, but we have data this, and this study was done about 7 years ago that we did, that the youngest physicians, those that were out 0 to 5 years, had the worst score on a question of my work is meaningful. And so those people should be the most excited, at least, back in the day. You're done with residency, you're finally arrived doing the job that you've been working for 12 plus years. You should be thrilled to be there, and they're not. And so what have we done that's caused that, or that's fostering that? And I think that's an important question to try to get to. I don't know the exact answer. I think there's some educational things where we've over-algorithmed people, and we've taken away their creativity and their ability to use their knowledge. And I think that's a negative. And we've taken the relationship out of the practice, including relationships between providers, where we used to have lunch together. There was a group of us and we watched Love Connection, as silly as that sounds. But it was something we did like most days, if we could, for a half an hour. And you'd walk down the hall and talk to people. Now you have instant messaging and the EMR. Most people eat lunch at their desk. So those little chinks that remove those connections and those mentoring opportunities, we need to figure ways to get back to that.
Yeah.
Tom, is that it, kind of on the concept of ROI? I think I'll just coin the term now. Maybe it's like emotional ROI or engagement ROI. Yeah. I don't think it's articulated well enough or as frequently enough in organizations, at least ones where I've been part of those conversations, where we do talk about improved experience, improving outcomes, and we do talk about reimbursement, going up with something like HCAHPS. But on the emotional engagement piece, I think we could show actually positive hard ROI there too, with things like, obviously physician retention and recruitment and some of that joy and work that you mentioned with those that are early to their practice. So maybe talk about that. What could organizations do to bring that part of the ROI conversation forward?
Yeah, I think we need to understand that we've made things transactional. And some of that has to do with the belief, I think, that millennials and Gen Zs in particular are transactional, right? They're not interested in a relationship in healthcare. I would challenge that in two ways. One is that the Walmart clinic, like full-scale Walmart clinics, that just hasn't, everybody predicted that was going to be the thing, excuse me, about 10 years ago, and it just hasn't happened. So for a variety of reasons. So that very transactional thing is not happening. Also, in healthcare, we've taken jobs that were more linear and relational and made them transactional. We have ED shift work. We have hospitalists, so most docs are not in the hospital doing inpatient care anymore. And there's good reasons for that, but you also have to understand there's a price for that. In OB, there's laborist. So the chance of you being delivered by the doctor or midwife or anybody else who's provided most of your care is much less than it used to be, where we'd go in for our own patients. So I think that we need to understand that and recognize it and find ways to build that back. I also believe that the Gen Z in particular, this is transactional until they want a relationship, and it's not. So just last week I had 2 people who are like, oh, where do you usually work? And I was actually filling in for somebody for just a couple weeks to help out. And I'm like, well, I don't work here all the time. But just in that 1 or 2 visits, you can make a connection, and people are like, I like this. I like having a connection. I want some consistency, and I want to have a relationship going through the rest of this pregnancy with you. So I think there's a belief that they don't seek it. Everybody seeks it. And it's just, we need to build that structure in somewhat as we move forward.
Yeah, I think that's really important. We have spent a lot of time digging into generational influences in healthcare, and particularly, you mentioned Gen Z, the Gen Z consumer. You're now seeing Gen Z in your practice. They are now actually aging into becoming healthcare consumers themselves. And so I think it will be interesting to watch to see how much their preferences disrupt some of our traditional points of view. That being said, you have spent a lot of time with probably hundreds of physicians over the course of the years, talking to physicians about how to embed what you call experience thinking into their practice. Would love to hear from you some of the barriers that you have heard, either real or perceived, and how you have helped some of those physicians to overcome those barriers, and maybe if you have an example that you could share.
So the obvious barriers for everybody, the one that pops up in my lifetime, that's the biggest change, is the EMR. And it's funny because I can vividly remember at my house watching 2 adult children, one who was a physician and one who worked for an EMR company, argue about the impact of the EMR. And if physicians would just do the training, it wouldn't be so bad. And if they just listen to us, and then the physician saying, you have no idea what my life is like, and how can you tell me those things? And they're both right, but they both lack perspective. And what I think we need to understand is that and AI is going to be an example of this, and we don't know where that's going to go, but it will be it's an inflection point and a minimum, and it's a paradigm shift probably.
Absolutely.
When you do something like that or bring something like that in, you can't just take your old work system and flows and hammer it in. And the example my son Connor came up with this analogy, so I don't take credit for it, but we had hammers and nails and we used to build stuff, right? Like that. We gave you a pneumatic nail gun, but you kept your same workflow. So you turn the nail gun on its side and you're banging the nail, and it's really expensive and it feels clunky because we didn't change our workflow from paper workflows. We shoved the paper system into this EMR. And as we continue to do that, we're gonna have to really think about how we change those basic assumptions, those workflows. Notes in EMRs now, notes on patients are lots of copy and pasting, move forward, which makes it simple for the clinician, but the notes are this long. Nobody reads them. It's not safer, but it fits the rules on how you have to do things. So, thank goodness CMS changed some of the rules on how you have to document for charges. That's a first step, but those things need to change. And I'll give you one other really pertinent example. I think at our small practice, we had 3 physicians working at a site in the health system in OB and 1 nurse practitioner. And for necessary reasons around lack of ultrasound techs, we had to change how we did OB ultrasounds. And we blew the thing up and said, if we were going to design this from the beginning, ground up, how would we do that? For the first 3 weeks, when we did that, a total change in the workflow, how they're scheduled, who's doing what, it was chaos. And I got calls 2 or 3 times a day and people running down the hall into my office. This is terrible. This person's scheduled for this and she's not supposed to come till Tuesday, and who messed this up? I'm like, you're right. We'll get there, but we're going to see this through. And at the end of the 3 weeks, it was vastly more efficient. The clinicians loved it. The patients were way better off. We're providing better care, and financially it was a win. But you have to accept the pain of being willing to change the assumptions in the workflows and build that system with relationships, because we all were a pretty high functioning team, and they were willing to give me the benefit of the doubt that I kind of knew what I was doing and that we were get through this. And so the ability to do that, I think, is really important, and the ability to foster those relationships going into these changes and then work through the change together and challenge the basic assumptions about how you do day-to-day work is what's going to carry us through.
Yeah. I love that you mentioned the paradigm shift. It actually brings us to a little section that we use in each one of our podcasts called the Executive Round, where we get perspectives from our different guests on effectively the same question. It's about the idea of the felt paradigm shift that we're all experiencing in healthcare. We've not yet arrived at the new one. Transformational forces are upon us from every direction. I think what we'd love to know, and what our listeners would love to know, is in what ways do you hope healthcare will transform in the coming years?
Well, and I think I just remember a comment from a former CEO at Mayo, John Noseworthy, who said the pace of change in healthcare today is as slow as it's ever going to be. So we're not going back to pace 10 years ago. Yep. It's just going to keep coming. More and more stuff's going to keep coming. The knowledge base is going to expand. You think about genetic medicine and personalized medicine, and this drug works for you but doesn't work for you, and we know that. So all of those things are going to accelerate. What I hope is that we'll have, the quadruple aim really becomes a thing that is true, that we have better outcomes, which includes access, that we have better experience for both patients and providers, and that the cost becomes reasonable. And I think we're seeing the experience kind of tread water. Maybe patient experience has gotten a little bit better. Provider experience, clinician experience over the last couple of years has somewhat rebounded from COVID, but still is, we're still way more burnout in healthcare than in almost any other profession. Right. And the cost has not gotten better. So hopefully the technology will help with those things, and hopefully we will get some traction around that, but it's going to require people to be willing to change how they do things, and at the same time protect the core thing that makes healthcare different from a lot of other industries is the necessity of relationship. And one of my favorite quotes is, the enemy of excellence isn't failure. It's acceptance of mediocrity. Mm-hmm. So we're going to have to try stuff. If it works, great. If it doesn't work, we learn something, and we'll move forward.
Right. Love it. Thank you. Dr. Tom Howell, thank you so much for joining us today on The Experience Shift.
Appreciate it very much. Thanks for the opportunity.